Good evening. Tonight's story isn't the usual gentle bedtime fable. It's the full arc of ketamine, a blunt yet ingenious anesthetic, born out of the urgency of combat medicine and later quietly igniting a revolution in mental health care. Put aside the neon club legends and overcooked headlines. The real narrative didn't begin on dance floors or in viral clickbait. It started under canvas in surgical tents, in fluorescent research labs, and in the hushed offices of doctors grappling with pain, consciousness, and despair. The reality is that if you were dropped into a wartime field hospital as a medic or a wounded soldier, you'd understand very quickly that anesthesia isn't a luxury item. It's a survival tool. And ketamine repeatedly became that thin, strange boundary between catastrophe and care. Before you settle in completely, tap the like button and subscribe if this kind of deep dive content speaks to you. Drop a comment with where you're watching from and what time it is for you. It's amazing to see people tuning in from so many corners of the globe. Silence your phone. Take a slow breath. Let's begin. The early 1960s carried the scent of solvents and ambition glassware gently heated under buzzing fluorescent tubes, and beer bottles tapping on stainless steel benches in labs convinced they could design kinder encounters with pain and awareness. Phencyclidine, the molecule that first seemed to herald a new era in anesthesia, had revealed its fangs. This sharp, heavy-handed compound PCP produced profound insensitivity to pain and a strange, often shocking psychosis. Patients drifted through unfamiliar inner landscapes and sometimes returned with nightmares, agitation, or long disordered awakenings that anesthesiologists and chemists alike found intolerable. The discipline needed something that preserved the helpful features, amnesia, analgesia, stable blood pressure, without the unwanted gift of lingering madness. By necessity and by temperament, the project became one of careful trimming, to take PCP's structure and cut away the danger. A small cluster of organic chemists at Park Davis in Ann Arbor and Detroit took on that project with the deliberate focus of artisans. They worked in an era when big drug companies ran their own labs like compact universities, where chemists could chase a hunch and guard a single bench for months at a time. Among them was a young organic chemist, Calvin L. Stevens, who sketched variant structures built on the aryl cyclohexylamine scaffold that defined PCP. The concept was strictly chemical, almost architectural. Preserve the cyclohexylamine backbone that appeared to drive strong anesthetic and pain-killing activity, but modify the attached groups to lower lipid solubility and alter how the molecule nestled into ion channels in the brain. Insert a carbonyl group. Swap a piperidine ring for a methylamino group. Experiment with an orthochlorophenyl ring. On paper, the adjustment was modest and elegant. In practice, it dramatically shifted the compound's character when the new molecule was finally synthesized in 1962 and recorded under the dry internal code CI 581. From the earliest manipulations, the goal wasn't to create a showpiece drug, but to contain a problem. PCP had been a charging bull. The challenge was whether chemists could transform that bull into a reliable workhorse. In this redesigned compound, a ketone at the 2 position on the cyclohexane ring and the methylamino side group narrowed the promiscuous binding that made PCP so chaotic in the central nervous system. A chlorine atom on the phenyl ring fine-tuned its strength. This new configuration suggested a shorter-acting, less lipophilic analog one that might edge along the fine border between a clinically useful anesthetic and a potential recreational psychotomimetic. Park Davis followed the rational path and allowed lab animals to deliver the first testimony. Rabbits, dogs, cats, and primates were given carefully calibrated doses as technicians monitored breathing, reflexes, heart rate, and behavior. Preclinical toxicology in the mid-1960s was thorough in a somewhat rough-hewn way. Dose-response curves, LD50 experiments, cardiovascular tracings, and behavioral logs that read like inventories of everything anesthesiologists dread. In monkeys, this new agent brought on a cautious, almost guarded calm. In dogs, it preserved spontaneous respiration. Compared with PCP, the compound that would later gain the name ketamine showed a shorter duration of effect and a strikingly different pattern of behavior. Animals did not become the terrified, prolonged automatons that PCP sometimes created. Reflexes stayed present. The near absence of serious respiratory suppression was deeply encouraging. Toxicology write-ups described hepatic metabolism, with rapid redistribution into fat and muscle, explaining both the brief anesthetic window and the acceptable gap between useful and dangerous doses. That safety margin mattered enormously. Hospitals in the lean 1960s did not have rows of ventilators or the intensive care fallbacks that modern anesthesiologists rely on. A drug that preserved airway reflexes and allowed people to keep breathing on their own could mean the difference between a safe induction in a makeshift field operating area and a devastating outcome. There was another advantage in the chemistry. The stereochemistry of the molecule built in the possibility of later separating its mirror image forms enantiomers, something that would become clinically important many years down the road. For the moment, Park-Davis distilled its cautious optimism into a name. CI-581 progressed through internal testing, into formal preclinical dossiers, and onto the desks of physician investigators, accompanied by equal parts hope and the kind of tired skepticism that only decades of medical practice can produce. The doctors who opened those parcels weren't thrill-seekers. They were pharmacologists and anesthesiologists who valued careful observation and liked solving practical, everyday clinical problems. In Ann Arbor, Edward F. Domino, a professor of pharmacology at the University of Michigan, stepped into the lead role for the first human trials. Domino and his colleagues, including Paul Chodoff and Gustav Corson, approached this new drug as they did all experimental compounds, methodically, incrementally, and with close attention to detail. Between 1964 and 1965, they recruited volunteers and surgical patients for small-scale studies, cautiously escalating doses and observing with keen clinical eyes tuned to subtle changes. Their reports from those years read in a delightfully dry, academic tone, but they pulse with a certain astonished clarity. The volunteers were not knocked completely unconscious in the way ether or barbiturates simply blotted out awareness. Instead, they seemed to be peeled away from reality at a deeper layer. Reflexes persisted, eyes might be open, pupils still reacted to light, yet the inner life, the sense of being there, appeared to have stepped elsewhere, leaving the body operating on autopilot. Domino coined the term dissociative anesthesia to describe this peculiar state of phrase that would sit in textbooks and echo through operating rooms for decades. The core properties that drove the drug's quick clinical uptake were practical, even prosaic. It preserved respiratory drive. It maintained cardiovascular stability. It provided dependable pain relief over a range of doses. Patients usually did not need immediate ventilatory support, unlike with many other anesthetics, and their blood pressure often held steady or even rose slightly, thanks to sympathetic nervous system stimulation. A biological quirk that could mean the difference between life and death in trauma or shock. For surgeons operating on unstable patients, for pediatric doctors trying to soothe a panicked child before a painful procedure, and for medics treating open wounds in environments where mechanical ventilators were a distant dream, those features translated into clear tactical advantages. The molecule that had been painstakingly shaped in glassware had arrived in a form clinicians could actually use at the bedside. To understand the odd balance, ketamine strikes separating awareness while preserving vital functions. It helps to zoom down to the molecular level. There, ketamine's main action is surprisingly neat and refined. It acts as a non-competitive antagonist at the N-methyl-D aspartate, NMDA receptor, one of the brain's key glutamate-gated ion channels. That receptor is not just a simple switch for excitation, it's a central player in synaptic plasticity and learning, orchestrating how experiences are encoded into neural circuits over time. Structurally, NMDA receptors are complex multi-subunit assemblies with a central pore that allows sodium, potassium, and crucially calcium to pass when glutamate and a co-agonist bind, provided the cell's electrical state is suitable. Both PCP and ketamine insert themselves into this open channel, but ketamine does so in a shorter-lived, state-dependent fashion. It prefers to bind when the channel is already open, acting like a cork jammed into the neck of a bottle, blocking ion flow without changing the receptor's outside binding sites. The net result is an abrupt dampening of excitatory signaling wherever those receptors are firing. When ketamine blocks NMDA receptors on specific cortical interneurons, something counterintuitive happens first. You effectively disinhibit the system. The GABAergic interneurons that normally keep pyramidal neurons in check lose some of their own NMDA-mediated conductance, so their inhibitory control falters. The outcome is a temporary surge in glutamate release from these now less restrained principal neurons. That glutamate wave then slams into a different receptor family, AMPA receptors. The flow through AMPA receptors becomes the crucial downstream switch, and the modern antidepressant narrative rests heavily on this step. Block AMPA receptors in animal models, and the rapid antidepressant-like effects of ketamine vanish. So by selectively knocking out NMDA receptor activity in certain cells, ketamine paradoxically jolts the network into a glutamate-driven state of heightened activity that, via AMPA receptor engagement, sets off a sequence of synaptic repair and rebuilding. The cascade playing out inside neurons after that glutamate and AMPA-driven jolt is where basic neuroscience and clinical hope converge. Activation of AMPA receptors increases synaptic depolarization and calcium transients, which stimulate the release of brain-derived neurotrophic factor, BDNF, and its binding to TRKB receptors. BDNF, in turn, flips on the mTORC1 pathway, the mammalian target of rapamycin complex 1A, master controller of protein synthesis. When mTOR is activated, it changes local protein translation at dendritic spines, ramping up production of synaptic components like postsynaptic density, protein 95, PSD 95, and AMPA receptor subunits such as GluA1. A translational break, EEF2 kinase, which normally restrains BDNF translation under baseline conditions, is inhibited in the presence of ketamine metabolites. That inhibition allows a burst of BDNF production within hours to days. Taken together, these shifts result in increased spine density and more functional synapses in the prefrontal cortex, a structural and physiological renewal that tracks closely with improvements in behavior in animal models of depression. This isn't a slow, gradual trophic effect. It's a rapid architectural refresh. Ketamine's biochemical calling card is this swift, efficient rebuilding of neural connections that chronic stress and mood disorders tend to erode. Its pharmacology also carries the signature of root and tissue. When given intravenously, ketamine crosses the blood-brain barrier quickly and starts working within a minute, often inducing the brief, characteristic tunnel sensation in which sensory input fragments and the patient becomes both anesthetized and oddly partially aware. Intramuscular injection brings a slower onset and more prolonged effect. Oral and rectal dosing are erratic and unreliable. Intranasal delivery, adopted later in psychiatry, offered a convenient middle ground with decent bioavailability. Metabolism takes place in the liver. Ketamine undergoes N-demethylation to form norketamine, an active metabolite that also provides analgesia and contributes to how long the overall effect lasts. The profile of metabolites and ketamine's tendency to partition into fat help explain why a single bolus can lead to a fast return of conscious perception, while a tale of pain relief lingers. Its receptor specificity is far from perfect. Ketamine is promiscuous enough to interact with opioid receptors, muscarinic sites, and monoamine transporters, and it binds to sigma receptors whose roles were murky then and remain somewhat enigmatic. These off-target actions add to its pain-relieving and psychoactive effects, but they don't dethrone the NMDA story as the central thread. The distinct enantiomers of ketamine also became part of its expanding tale. the S-enantiomer esketamine binds NMDA receptors more potently than the R form. Decades later, that difference would be harnessed in clinical development. But in the early days, trials used the racemic mixture. Only in later years did the subtleties of chirality shape regulatory decisions and marketing strategies. When Domino and his team published their first human series in the mid-1960s, their writing was appropriately balanced and careful, but the implications were electrifying. They described patients who, under ketamine, could undergo brief surgical procedures without paralysis or apnea. People kept breathing on their own and retained basic reflexes while surgeons worked. They also noted the peculiarities: emergence reactions, intense dreams, sometimes distressing hallucinations, and confusion when waking. Adult patients often needed mild sedatives afterward to ease the transition back. Children, however, generally weathered the experience with less trouble, a detail that would draw pediatric anesthesiologists toward the drug with relief and appreciation. For obstetricians and trauma surgeons, the overall profile was compelling. The sympathetic stimulation ketamine provided could help sustain blood pressure in bleeding patients, and its preservation of airway reflexes reduced the need for intubation in resource-limited settings. The U.S. Food and Drug Administration processed the application with the same empiric caution that had marked the trials. Parke-Davis shepherded CI-581 through the regulatory system, and after a patchwork of reviews and promises of post-marketing surveillance, ketamine marketed as Kettler received approval for human anesthetic use around 1970. Timing shaped its fate. The Vietnam War was intensifying, and military medicine tends to adopt pragmatic tools quickly. American medics discovered ketamine's strengths in field hospitals and evacuation centers. A medication that could be given intramuscularly, rarely stopped breathing, and relieved both pain and anxiety was a logistical blessing when ventilators were scarce and wounded soldiers were plentiful. There is an uncomfortable reality here. Wars speed up the use of certain medical technologies, not because they are perfectly suited to the task, but because they are simply workable under terrible conditions. Ketamine fit that harsh template. Back in civilian life, its spread was driven by practical needs. Operating rooms across the US and Europe began to keep it in stock. In rural clinics and mission hospitals across sub-Saharan Africa and in parts of South and Southeast Asia, the drug's ease of use and safety made it indispensable where anesthesia machines and oxygen supplies were unreliable. The World Health Organization would later designate ketamine as an essential medicine for anesthesia and analgesia in low-resource settings, essentially putting a formal stamp on what frontline doctors already knew. Veterinarians quickly embraced it as well. Its predictable pain control and relative lack of severe respiratory suppression made it useful in species ranging from dogs to horses. Yet the clinical picture came with warnings and carefully constructed responses. Emergence phenomena, hallucinations, agitation, dysphoric reactions were not just occasional curiosities, they could be deeply unsettling. Anesthesiologists learned early to pair ketamine with benzodiazepines or barbiturates to soften these recoveries, and practice guidelines evolved that favored combination regimens rather than using ketamine solo, at least for adults. Protocols for pre-medication, intraoperative monitoring, and post-op nursing care circulated through professional meetings and journals, and training emphasized the drug's quirks as much as its advantages. Scaling up didn't only require more production at Parke-Davis. It also demanded that surgeons, anesthesiologists, and military medics be trained on when ketamine excelled and when it needed a partner drug to make the re-entry into consciousness less dramatic. The logic behind its adoption remained pragmatic. In emergency departments, the drug's quick onset and brief anesthetic duration made it ideal for painful procedures, suturing, fracture reduction, short orthopedic surgeries without requiring full general anesthesia and intubation. In pediatric wards, its relatively gentle emergence profile in children encouraged its use for painful diagnostic tests and minor operations. In trauma care, its ability to support blood pressure in hypertensive patients made it preferable to agents that tended to lower it. For the first 10 years of its clinical life, ketamine's story was mostly that of a tool discovered and deployed because it solved a set of tough logistic problems. Yet scientific curiosity never truly rests. As ketamine's use grew, researchers took note of its effects at sub-anesthetic doses. Durable analgesia, reduced need for opioids, and in scattered case reports, surprisingly fast antidepressant responses in patients whose mood disorders had resisted almost everything else. Those early hints would take decades to link into the synaptic renewal narrative that now energizes psychiatry. But the pattern was already there for anyone paying close attention. NMDA blockade enhanced glutamate throughput, strengthened synaptic signaling. A drug designed to be a safer anesthetic was revealing a biochemical flexibility that kept quietly inviting people to rethink what it might be for. Over the half-century from its synthesis to the modern era, ketamine traveled a long path, from lines on a chemist's notepad to vials in a hospital, from an experimental anesthetic to a staple battlefield analgesic, from a comfort drug for children to a broad-spectrum tool for emergency care. Design decisions, adding a ketone to trim lipid solubility, using a methylamino group to moderate potency, placing a chlorine to tune receptor binding, had produced exactly what pharmacologists had hoped. It could anesthetize without cutting off breathing. It relieved pain without crashing blood pressure. And it left a deep, still unfolding mark on synaptic biology. In quieter terms, ketamine showed clinicians that you could temporarily uncouple the mind's theater from the body's machinery and still keep that machinery running. Breathing, circulation, reflexes intact, while inner experience dimmed or drifted away. That paradox-preserved physiology with altered consciousness became the central axis around which early adoption spun. It made sense in practice. It raised moral questions. It made possible a future in which a drug forged for war might eventually be used to treat despair. The chemical narrative was relatively straightforward. The human one would be much knottier. But in those years, in the Parke-Davis labs, in the wards of Ann Arbor, and in the field hospitals of war, this new compound turned into a tool that answered immediate questions with quiet effectiveness, and people noticed. In the operating room, its mechanics played out right in front of clinicians' eyes. An anesthetist injected an IV bolus and watched the patient drift into a state that was both strange and clinically manageable. NMDA receptor blockade smoothed out the pathways of pain. NMDA receptors in the spinal cord that normally drive central sensitization were damped, so patients experienced both pain relief and less of the wind-up phenomenon where pain escalates with repeated stimuli. Meanwhile, cortical networks that usually knit together a single unified conscious experience broke into more independent streams. Thalamic relay systems that normally deliver sensory input to awareness lost some of their tether to the cortex. A patient's eyes might still follow a light. Toes might pull back from a pinch. The automatic rhythms of life-breathing, heart rate regulation kept ticking along. The surgeon could continue. Later, the patient might recount odd stories of being somewhere else, in another room or another world. Sometimes the accounts were terrifyingly vivid. Clinicians learned to treat these narratives as part of ketamine's recognizable signature, anticipated theatrics that warranted advance framing, pre-medication, and occasionally a mild sedative during awakening. The now familiar molecular sequence NMDA blockade, glutamate surge, AMPA receptor activation, mTOR-driven protein synthesis, synapse formation is tidy in hindsight. But it took decades of animal experiments, electrophysiology, imaging work, and relentless replication before it solidified into something like a paradigm. The earliest users didn't need all that to put ketamine to work. They needed a drug that succeeded where others came up short. Yet as researchers chased the compound into cortical slices and into the tiny spines of stressed neurons, the synaptic repair story accumulated evidence. Ketamine wasn't just toggling pain and awareness off for a while. At certain dosing strategies, it was gently nudging the brain towards structural reorganization. Those biological revelations widened the drug's stage beyond operating rooms and field hospitals. Sub-anesthetic IV infusions turned out to relieve chronic neuropathic pain. Single low doses produced pain relief that lasted longer than pharmacokinetic models predicted, a mismatch later attributed to both the metabolite profile and synaptic adjustments in the spinal cord and cortex. A handful of clinicians noticed something deeper: shifts in mood in their patients, a lifting of depressive symptoms that appeared in hours instead of weeks. The effect was startling, inconsistent, and impossible to ignore. Eventually, it would drive controlled trials and force a reimagining of what an anesthetic could be. For the moment, the narrative remained grounded in everyday usefulness. Ketamine tightened the margin of safety in situations where time and equipment were scarce. To scale this up took more than enthusiasm. It needed factories, supply chains, and the slow-turning gears of regulatory approval. Park Davis ramped up production. Hospitals figured out storage and staff training. Military guidelines absorbed ketamine into recommended emergency toolkits. At the same time, professional societies and medical journals debated best practices: which patients should receive ketamine alone, when to add a benzodiazepine, how best to manage emergence reactions, and whether IV routes were superior to intramuscular ones. This grounded debate, based on data and shared experience, seeded a kind of cultural spread. Younger anesthesiologists learned ketamine during training, and its reputation flowed through mentorship, lectures, and case reports. History loves irony, and ketamine offers one with almost Victorian flair. Built to tame PCP's chaos, it did exactly that in many arenas, only to acquire, later on, its own patterns of misuse and cultural distortion. That, though, belongs to a different chapter. In the 1960s and 1970s, the story was still about a practical, elegant fix to the pressing problem of keeping people alive and out of agony when the tools of the day were crude. It was a modest sort of revolution. A molecule redesigned to be safer, vetted in animals, then in carefully observed human volunteers, and finally dispersed across hospitals and battlefields because it suited the realities of medicine. If you close your eyes and picture those labs, you might still catch the smell of lacquer and solvent, see the pale faces of researchers bent over lab notebooks, and hear the quiet precision in the voices of clinicians in a pre-op holding area. This history isn't just a roll call of dates and names, although those matter. Calvin L. Stevens at Park Davis, Edward F. Domino at the University of Michigan, Paul Chodoff and Gustav Corson among the first clinical chroniclers. It's also the shared story of systems reacting to constraints, the lack of ventilators, the urgency of trauma, the need to make anesthesia workable in an unevenly resourced world. Ketamine found its home by answering those needs with a kind of chemical frugality: do less harm, protect as much function as possible, and send the patient back into life intact enough to continue. That ethic, doing enough, but not too much, remains part of ketamine's legacy. It enabled surgery in settings that might otherwise have been marked by silence and loss. It launched a body of research into the molecular dance of consciousness and mood, and it left behind a tool that would later be reshaped and reinterpreted long after the first chemists had washed their flasks and gone home. The journey from PCP's problems to ketamine's cautious victory is a compact story of chemistry, close observation, and clinical realism. It shows what can happen when a field decides to keep what works and redesign the rest. Sleep, in that calm mid-century sense, came a bit more easily to anesthesiologists after ketamine arrived, not because every issue had been solved, but because some of the most worrisome ones had been eased with quiet efficiency, keeping hearts beating, lungs breathing, and surgeons operating when other agents would have demanded more gear or more risk. The later chapters in ketamine's biography, its intricate pharmacology in finer neuronal detail, its reinvention in psychiatry, the cultural and ethical storms it would stir up, would all grow from this no-nonsense origin. For now, the story of a safer anesthetic begins with a chemist's corrections, a calm laboratory animal, an oddly drifting volunteer, and a hospital system ready to adopt what worked. In its unobtrusive way, it became one of medicine's stubborn little triumphs. An engineered restraint that gave clinicians a new degree of control at the most intimate boundary between mind and body. In the dim, battered light of forward aid stations, under the rotor thump of helicopters, ketamine proved itself not as an elegant lab concept, but as an answer to brutal, immediate questions. How do you provide safe anesthesia or meaningful pain relief when there's no stable IV access, when the patient is bleeding, when evacuation timing is uncertain, and every minute is borrowed from disaster? Ketamine's wartime story isn't one of glamour. It's a quiet arithmetic of properties weighed against urgency. It took root precisely where many other drugs failed. It could be injected into muscle when veins had collapsed. It almost never paralyzed breathing. It supported blood pressure instead of driving it down. And it acted fast enough that medics learned to synchronize their injections with the choreography of field care and evacuation. American and Allied physicians and medics in Vietnam were among the first combat clinicians to experience these advantages day after day. In tented aid posts under flickering bulbs and mosquito netting, anesthesiologists and flight medics adapted ketamine to the demands of frontline surgery and transport. Dust-off helicopters lifted the injured from rice paddies, jungle clearings, and cratered roads. In the cramped time between pickup and arrival at a mobile army surgical hospital, a medic could administer ketamine intramuscularly and buy precious minutes of relative comfort, dissociation from pain, and preserved airway reflexes. Because ketamine separated perception from consciousness without deeply depressing respiration, it fit the erratic geometry of combat medicine. Wounded soldiers could be handled, loaded into aircraft, and undergo urgent procedures without the high apnea risk associated with barbiturates or then-current IV induction agents. The math was merciless but simple. Fluids were limited. Blood products were scarce. Hypertension was common. Many induction drugs could push a patient straight into circulatory collapse. Ketamine, through its ability to increase or stabilize catecholamine tone and its sympathomimetic profile, often nudged blood pressure upward or at least held it level. That did not make it universally safe. In patients already wrung dry of catecholamines by prolonged shock, ketamine's underlying myocardial depressant properties could surface. But in the overwhelming majority of battlefield scenarios, it was the rational choice. Surgeons realized that the earlier fears about hallucinations and emergence reactions could be contained with small doses of benzodiazepines when available, and that the hemodynamic benefit of keeping organs perfused usually outweighed the cost of a vivid, disorienting dream. Those treatment decisions were never purely medical. They were also decisions about logistics and doctrine. Military medical supply chains began stocking ketamine in forward resuscitative packs and surgical kits because it solved a persistent operational headache. The drug's stability at room temperature, its high potency in small volumes, and the simplicity of intramuscular administration meant it could be tucked into individual medic bags, field surgical crates, and helicopter medical lockers without special refrigeration or complex reconstitution steps. The same chaotic environments where soldiers bled and surgeons bartered with time were the places where ketamine's shelf life and handling simplicity became decisive. In the relative stillness of a field hospital, anesthesiologists sometimes scrawled dosing guidelines on the inside of equipment lids. Intramuscular induction for shocky, poorly vascularized patients, IV for controlled inductions, lower subdissociative doses for analgesia. Over time, improvisation hardened into standard operating procedure. There were tensions between doctrine and on-the-ground judgment. Early military caution around ketamine use in head injuries grew from small studies and anesthetic dogma suggesting it might raise intracranial pressure. Some neurosurgeons and anesthetists steered clear on principle. Yet the brutal immediacy of field conditions forced reconsideration. Over subsequent years, as more outcomes data accrued and combat clinicians published results, evidence suggested that ketamine did not generally worsen neurologic outcomes and could be safely used even in traumatic brain injury when accompanied by disciplined airway and blood pressure management. That course correction wasn't abstract. It reshaped what went into medkits and how medics were trained. When soldiers and corpsmen in Iraq and Afghanistan later pushed ketamine for analgesia or used it to facilitate intubation under fire, they were relying on a grammar of practice refined decades earlier on different battlefields. The age of asymmetric warfare, desert campaigns, mountain patrols, urban firefights, from the first Gulf War in 1991 through the conflicts in Iraq and Afghanistan in the 2000s and 2010s, added new lines to ketamine's story. The doctrine of tactical combat casualty care, TCCC, developed in the late 1990s and sharpened through the 2000s by military emergency physicians and trauma experts, placed pain control and early airway management at the very center of life-saving interventions. Ketamine, with its ability to be given intramuscularly when IV lines couldn't be established, and its predictable hemodynamic profile, became a favored agent in TCCC kits, especially for special operations and forward surgical teams working far beyond conventional hospital support. The US and British militaries, among others, integrated ketamine into their medic and corpsman training curricula, specifying dose ranges and co-medication strategies, pairing ketamine with low-dose benzodiazepines when feasible to soften emergence reactions, or using subdissociative infusion rates for ongoing pain relief during prolonged field care. Practical logistics. The question of how a loaded syringe reaches a medic's hand in a remote position were as decisive as any receptor-binding data. Defense departments awarded bulk contracts to generic manufacturers capable of producing large volumes of ketamine at low cost. Industrial-scale production by firms in India, China, and elsewhere ensured a steady supply. Distribution systems optimized for ruggedness meant ketamine was frequently issued in labeled ampules or pre-measured syringes, minimizing dosing errors under the stress of combat. That standardized packaging fed back into civilian medicine. Emergency medical services, EMS agencies, watching military outcomes and after-action reports began in the early 2000s to adopt ketamine protocols for pre-hospital analgesia and sedation. The protracted, complex evacuations that typified certain theaters' multi-hour delays to extraction, or extended battlefield surgeries in small forward units cemented ketamine's status as an anesthetic of choice in austere conditions. Coalition forces in Afghanistan, treating blast injuries in mountain villages, came to rely on it not just because it worked, but because it was flexible. It could be delivered through an intraosseous line when peripheral veins were inaccessible, via IV when available, or IM when nothing else was practical. That multi-route adaptability dialed up the drug's strategic value. One agent, many options. Battlefields also taught clinicians how to live with ketamine's idiosyncrasies. Emergence reactions and hallucinations, once seen as almost disqualifying, became manageable phenomena. Small adjunct doses of benzodiazepines took the edge off. Excess salivation was often controlled with anticholinergic medications when they were on hand. Otherwise, careful positioning and suction sufficed. Vomiting risk was mostly handled with posture and suction, more than with prophylactic antiemetics. Training emphasized anticipation. Expect dissociation. Prepare to handle agitation if it arises, and always remain alert to the rarer cases of cardiovascular depression in exhausted catecholamine-depleted patients. The practical insights captured in military field manuals gradually seeped into civilian emergency rooms, subtly reshaping what doctors perceived as safe in pre-hospital pain management and sedation. That slow migration was driven partly by necessity. Civilian ERs have long struggled to balance reliable analgesia and procedural sedation for agitated, combative, or frightened patients, whether that's a child refusing to hold still or an adult trauma victim at high risk for respiratory compromise if given large opioid doses. The armed forces' validation of ketamine in uncontrolled real-world settings, helicopters, tents, patrol bases, helped lower the psychological threshold for civilian use. Emergency physicians in cities like New York, London, and Sydney began to run low-dose ketamine infusions for severe pain, use it to provide safe anesthesia for quick procedures, and sedate children who needed urgent laceration repair or foreign body removal. Adoption spread unevenly but steadily. Over time, ketamine settled into the emergency clinician's toolkit, no longer a niche drug confined to anesthesia subspecialists. Pediatrics provided one of the clearest demonstrations of practical necessity morphing into preference. Children bring unique hurdles, tiny veins that collapse under stress, high fear and movement when they're prepped for procedures, and a heightened vulnerability to respiratory suppressing sedatives. Ketamine's package of properties, analgesia, amnesia, and preserved spontaneous breathing, made it a natural fit for pediatric emergencies and minor surgical work. From Boston to Melbourne, pediatric anesthesiologists and ER doctors in the 1970s and 1980s increasingly favored ketamine for procedural sedation, resorting to intramuscular injections for struggling toddlers and IV boluses for older, more cooperative kids. Over time, practice refinements routine ondansetron to reduce nausea, glycopyrrolate to curb secretions, and dose adjustments to minimize emergence reactions smoothed the clinical pathway. Intranasal delivery, emerging as a non-invasive option in the 1990s and gaining traction in the 2000s, allowed paramedics and ED staff to control pain in children without ever placing a needle, whether at bedside or in the field. Still, a shadow followed this enthusiasm. Animal research from the late 1990s into the 2000s suggested that repeated or prolonged exposure to anesthetic agents in immature rodent and primate brains could trigger neuroapoptosis-programmed cell death. That raised alarms about potential long-term neurodevelopmental consequences of early life exposure to anesthetics, ketamine included. Regulatory agencies issued cautious advisories and called for more human data. For ketamine, findings were mixed, and the debate complicated decision-making around repeated or lengthy pediatric sedation. Clinicians weighed immediate benefits, preventing severe pain, stress, hypoxia, and traumatic memories, against theoretical long-term risks. Research priorities shifted. Could developmental outcomes be tracked in children receiving single versus multiple exposures? How should high-dose, long-duration animal studies be interpreted in light of the brief or subdissociative uses common in pediatric emergency care? Meanwhile, veterinary medicine provided a separate but parallel avenue of expansion. In that world, ketamine became a workhorse. It sedated dogs, cats, horses, and a range of wildlife with a dependability that quickly made it indispensable. Large animal practice embraced ketamine for both safety and the feasibility of remote administration. It could be delivered in dart form to immobilize an elk or giraffe, something many other anesthetics simply couldn't do. Zoo veterinarians, farm animal practitioners, and wildlife conservation teams used ketamine when immobilizing animals for surgery, transport, or relocation. This broad veterinary demand helped keep ketamine cheap and abundant. Pharmaceutical manufacturers across Asia ramped up output to satisfy both human and veterinary needs, shipping millions of vials to clinics and farms. The merging of civilian medical use, military procurement, and veterinary markets produced a global supply chain robust enough to place ketamine within reach, even in severely under-resourced areas. That reach had predictable side effects. Wherever ketamine was plentiful and inexpensive, diversion followed, not always in the dramatic fashion depicted on crime dramas. Sometimes it was just slow leakage from veterinary inventories, gaps in hospital security, or informal rerouting of surplus stock. Regions with lighter regulation of veterinary drugs saw ketamine slide into recreational circuits more easily. In parts of Asia during the 1990s and early 2000s, and later in European and North American club scenes, the drug's migration from clinic to nightlife became a visible social reality. The same features that made ketamine invaluable in war zones, stability, injectability, low manufacturing cost, also made it attractive as a dissociative party drug. Its cultural aftershocks in nightlife and recreational settings rolled out in waves. In the club culture of the UK in the late 1980s and 1990s, tightly linked to emerging rave and electronic dance scenes, ketamine was picked up for its distinctive dreamlike dissociation. It warped time and space in ways that fit the sensibilities of those environments. It was cheap, easy to transport as powder or liquid, and simple to share. Nicknames proliferated: K, Special K, and playful branding that sometimes borrowed from child-friendly imagery. Rituals formed around the K-hole, a vernacular term for the intense, high-dose dissociative state in which users reported floating outside their bodies, moving through slowed or frozen time, and occasionally experiencing terrifying paralysis. The language of the club and the language of the clinic barely touched. Doctors spoke of dissociative anesthesia. Clubgoers described falling through the floor or sliding into a void. Each description captured part of the truth. Mass media amplified both novelty and danger. Tabloids loved the clean narrative, a legitimate hospital drug turned into a way to lose oneself on the dance floor. Sensational pieces highlighting traumatic accidents or psychotic breaks fed moral panics and fueled policy debates. Governments faced a familiar dilemma: tighten control to curb recreational harm, risking collateral damage to medical and veterinary access, or keep supply lines open for legitimate care while accepting more diversion and misuse. Many countries moved towards stricter controls through the 2000s and 2010s. Others resisted international scheduling, arguing that limiting ketamine could cripple anesthesia services in low-resource surgical settings. The World Health Organization's expert committees repeatedly weighed the public health risks of recreational misuse against ketamine's status as an essential anesthetic, especially in nations without ready access to safer or more expensive alternatives. These weren't purely theoretical discussions. Real, specific harms were emerging in high-use communities. Clinicians began documenting a disturbing pattern among heavy recreational users: serious urinary tract damage and bladder disease. Urologists in cities across East Asia, particularly Hong Kong, started seeing young adults with a strange, aggressive form of cystitis in the early 2000s. These patients, often in their 20s, presented with extreme urinary frequency, urgency, severe suprapubic pain, and blood in the urine. Investigations showed shrunken, scarred, fibrotic bladders, sometimes so damaged that reconstructive surgery or even bladder removal became necessary. The condition, termed ketamine-induced cystitis, was linked closely to chronic high-dose use. Pathologists found ulceration, hemorrhagic inflammation of the bladder lining, and progressive fibrosis. By 2007-2008, case series in urology journals alerted clinicians worldwide to this new syndrome. Animal models and cell culture work suggested that ketamine and its metabolites in urine could exert direct toxicity on the urothelium in susceptible individuals. Early cessation could lead to partial recovery. Years of heavy exposure could carve lasting damage. Public health advisories spread through affected regions. For a drug long trusted to keep patients safe through surgery and trauma, the idea that it could cause a young person's bladder to contract into a painful, non-functional shell felt like a profound betrayal. Psychiatric and cognitive harms also entered the discussion. Case reports and observational studies suggested that chronic heavy use might be associated with memory deficits, trouble with attention and executive function, mood disturbances, and increased risk of persistent psychosis-like experiences. Direct overdose deaths from ketamine alone remained relatively rare, since it seldom produced the profound respiratory depression seen with opioids. But fatalities linked to accidents, polydrug combinations, or dangerous behavior while deeply dissociated were not rare enough to ignore. Media accounts often overstated the frequency and direct causality of these outcomes, but clinicians and public health authorities took the underlying evidence seriously. All of this produced a complicated cultural stance. Ketamine's mystique in underground scenes invited curiosity. while its documented physical and psychological harms justified alarm. That cultural turbulence fed back into medicine and research. The stigma attached to recreational use complicated clinical trial recruitment and made policymakers hesitant to fund broader ketamine studies beyond anesthesia. Yet the very attributes that attracted partygoers, its rapid distortion of conscious experience and its influence on glutamatergic signaling, drew the attention of psychiatrists who were desperate for faster-acting antidepressants. In the early 2000s, a handful of small clinical reports suggested that low, carefully controlled IV doses could trigger rapid reductions in suicidal thinking and depressive symptoms within hours or days, a staggering contrast to the weeks required for standard antidepressants. Suddenly, the narrative split. Here was a compound vilified in tabloids, yet in academic hospitals, under strict monitoring, it seemed capable of dramatically lifting some of the darkest human suffering. Media coverage followed with its usual volatility stories of miracle cures and party drug antidepressants, often blurring critical distinctions between supervised clinical infusions and unsupervised recreational use. The public heard fast antidepressant and imagined quick fixes. Clinicians stressed dose, setting, supervision, and careful screening. Ketamine's cultural biography grew three distinct faces: battlefield anesthetic, mainstream tool in pediatrics and emergency medicine, and recreational dissociative with real potential for harm. Each identity refracted the others. Policymakers tried to design regulations that could disrupt recreational markets without choking off access for hospitals in low-income regions or for legitimate pain and psychiatric uses. Researchers navigated public skepticism and uneven funding. Clinicians tried to hold both truths at once: ketamine as a life-saving intervention and ketamine as a substance that could devastate when used chronically and without oversight. In clubs and festival fields, harm reduction communities adapted, teaching users to avoid binge patterns, to stay hydrated, to test substances, and to be cautious when mixing depressants. Ketamine didn't lend itself to syringe exchange-style interventions as neatly as opioids did, but community education still cut down some acute harms. In medical circles, best practice guidelines multiplied. Screen psychiatric ketamine candidates for substance misuse. Monitor urinary symptoms in heavy users. Adjust emergency department protocols to recognize that a ketamine-intoxicated patient might be profoundly dissociated yet breathing adequately. There's a sharp irony in all this. The same qualities, chemical stability, flexible routes of administration, and hemodynamic friendliness that made ketamine a pillar of battlefield care also made it a cheap, appealing escape in late-night urban culture. But both uses share a deeper pattern. When pain is immediate and resources, whether medical or psychological, are limited, people reach for what works. Soldiers and surgeons used ketamine to hold life together in dirt floor wards. Clubbers used it to dissolve themselves into altered nights. Psychiatrists later reached for it to interrupt suicidal cascades. Each context taught clinicians something different about the drug, its power, its boundaries, and its costs. Throughout all this, notions of safety and risk were constantly renegotiated. Military experience highlighted robustness under pressure. Pediatric and emergency medicine emphasized respiratory stability and flexibility. Veterinary practice underscored sheer global volume and reach. Recreational use exposed harms that had been invisible when ketamine was seen only through the narrow lens of operating rooms. Media narratives often mashed these domains into either moral panics or breathless miracle stories. Reality was far messier and more interesting. Ketamine was at once a sturdy workhorse and a wild agent, resisting any single tidy definition. If you look for symbolic pivot points, the key moments aren't dramatic headlines, but ordinary administrative choices. The decision to include ketamine in standard medic kits. The printing of laminated dosing cards for IM administration. The change in EMS protocols authorizing paramedics to use subdissociative ketamine for pain or severe agitation. The opening of a clinic offering monitored ketamine infusions for treatment-resistant depression. These are the hinges on which the drug moved from one sphere to many. With each transition, ketamine's social meaning shifted, often unpredictably, from battlefield anesthetic to children's sedation aid, to vet clinic staple, to club drug, and then to novel psychiatric intervention. If you trace that history slowly, there's an odd tenderness to it. Field doctors in canvas tents improvising to keep blood pressure out of free fall, pediatric nurses comforting sobbing toddlers as they drift into painless, protected sleep, wildlife vets darting an antelope under a wide night sky, a crowded nightclub where identities and bodies blur under strobes for a few hours. In every scene, people are using the same molecule to confront vulnerability, whether the vulnerability is a broken limb, a terrified child, a captured animal, or a mind that has cracked under depression. The lessons are not romantic, they're practical. Ketamine forced medicine to think more carefully about context and contingency, and it pushed society to confront difficult questions about access, control, moral judgment, and stigma. By the time ketamine's psychiatric potential hit the mainstream in the 2000s and 2010s, the cultural landscape around it was already crowded with wartime stories, pediatric protocols, veterinary usage, and club myths. Research centers moved carefully, designing randomized trials and safety monitoring routines that acknowledged this baggage. Clinicians who had used ketamine in tents and ER bays now found themselves validating a very different role: small, structured infusions to produce rapid antidepressant effects. Their clinical excitement was tempered by the knowledge that unsupervised, widespread use could replay the harms documented in recreational users. So when psychiatry's quiet revolution finally took shape, it didn't arrive with a clean slate. It arrived messy and incremental, championed by many of the same practical clinicians who had learned to trust ketamine when a tourniquet, a helicopter, and a few minutes of stability meant the difference between life and death. It was complicated by global supply chains that fed hospitals and clubs alike, by regulatory puzzles about balancing access and control, and by the stubborn fact that the drug's effects are powerful enough to reshape inner experience in ways that can heal but also destabilize. Ketamine's historical arc, from operating room to battlefield, from pediatric ward to dance floor to psychiatric infusion suite, is a study in adaptation. It's about techniques refined in dusty aid stations and carried back into hospitals, ambulance systems, and veterinary practices. It's about unintended cultural consequences when a plain clinical tool turns into a psychoactive commodity. And it's about how urgency bleeding, fear, physical pain, or suicidal despair reshapes both medical practice and social meaning. The molecule itself is indifferent. It has no aims, only properties. It is clinicians, policymakers, users, and storytellers who weave narratives around it. That it heals, that it destroys, that it comforts, that it deranges. Those narratives collide and sometimes reconcile at the edges of practice. In those frictions, the larger human questions, the ones about risk, responsibility, and care, persist. And so, after the helicopter rotors, the warehouse raves, and the dim-lit psychiatric treatment rooms, the story continues in quiet ways. Medical teams in remote clinics still depend on ketamine to provide safe anesthesia when their supplies are scant. Emergency departments still use it for frightened kids or painfully locked joints. Veterinarians still trust it to immobilize wild animals as gently as possible. Researchers still probe its mechanisms, tweak dosing strategies, and track long-term outcomes. Policymakers still argue over how to square access with control. Public health workers still counsel those whose lives or bodies have been damaged by chronic misuse. Ketamine's history isn't a closed case. It's a book that keeps getting new chapters, written daily in clinics, tents, and labs worldwide. Like any truly useful instrument, its story is braided into practical realities. Supply chains, training standards, treatment protocols, and the messy, urgent needs of real people. To understand ketamine's darker balance sheet, you have to see how quickly its clinical elegance can tilt into clinical trouble. What feels like a marvel in one setting, an anesthetic that blunts pain while preserving spontaneous breathing, can in another turn into a corridor of unsettling experiences, cardiovascular jolts, and for a smaller subset of people, a long destructive trail of organ damage. In operating rooms, ketamine earned its rank as the prototype of dissociative anesthesia, a phrase from the earliest human studies meant to capture the uncoupling of sensation from the sense of self. Those same properties, which proved so valuable in war zones and emergency departments, would decades later frame the anxieties when psychiatrists began using ketamine for mood disorders. At subanesthetic doses, and certainly at the higher anesthetic levels used in the 1960s and 1970s, ketamine can bend perception into a new grammar. Sounds can feel textured. Faces seem to soften or distort. Rooms appear to obey a different physics. Patients report out-of-body experiences and transient hallucinations. These are not just poetic metaphors. They're captured in sober clinical language as derealization, depersonalization, and perceptual distortions. Early reports from the US and UK describe episodes in which patients felt detached from their limbs, from their own story, as though their consciousness had stepped away to scout another dimension briefly. The onset of this state is rapid. Dissociation can sweep in within minutes after an IV bolus and then ebb over the next half hour or so. For the majority of people, this is short-lived, a disorienting interlude noted by clinicians and rarely idealized by patients once they're fully clear-headed. For some, it's frightening, a psychosis-like condition that, in people vulnerable to schizophrenia or with a strong family history of psychotic disorders, can precipitate full-blown psychotic symptoms. This caution wasn't hypothetical. Early psychiatric ketamine trials deliberately excluded individuals with past psychosis or strong psychotic risk. Beyond the perceptual landscape, ketamine's systemic pharmacology has concrete physiologic consequences. It is a sympathomimetic agent. It tends to raise heart rate and blood pressure. That's a blessing in the hands of a trauma surgeon trying to get a hypertensive patient through induction. It's a warning sign in someone with uncontrolled hypertension or serious coronary artery disease. Nausea, vomiting, nystagmus, and at higher doses transient respiratory depression all appear on the standard side effect checklist. As more refined randomized psychiatric studies rolled out around the turn of the millennium, strict monitoring of vital signs and exclusion of patients with uncontrolled cardiovascular disease became routine. Dose choices became a compromise between clinical benefit and manageable side effects. The now classic subanesthetic infusions 0.5 mg over about 40 minutes weren't designed for mysticism. They were engineered for control. Cognitive and neurodevelopmental concerns were slower to crystallize. They surfaced not in tidy randomized trials, but in the messy sprawl of real life across club scenes, outpatient addiction programs, and urology clinics. Cross-sectional neuropsychological studies in Europe, Australia, and Asia in the 2000s describe deficits in frequent recreational users, problems with working memory, attention, and certain executive functions. These impairments correlated imperfectly but consistently with cumulative exposure. Imaging studies reported changes in the prefrontal cortex and hippocampus regions critical for planning, memory, and emotional regulation. Animal studies going back to the 1970s had already raised concerns about excitotoxicity and vacuole-like lesions in developing brains after prolonged NMDA antagonist exposure. Clinically, this translated into immediate caution around repeated or extended ketamine exposure in children and pregnant women. Regulatory bodies later issued warnings about possible neurodevelopmental risks. These weren't framed as definitive verdicts, but as prudent alerts in the face of incomplete evidence. Tolerance and dependence sit in a gray zone between biology and behavior. Ketamine is not an opioid. It generally doesn't trigger the same intense physical withdrawal profile seizures, temperature swings, severe autonomic instability. But it does have reinforcing properties. In lab models, rodents and primates will self-administer ketamine. In humans, a recognizable pattern: binges, escalating doses, compulsive seeking, has been documented among some recreational users. Tolerance to the desirable dissociative and euphoric effects builds over time. Psychological dependence, the strong urge to reopen ketamine's escape hatch from pain, boredom, or low mood, has become a tangible clinical problem in certain populations. When easy supply meets social ritual, as it did in nightlife scenes from London to Hong Kong, repeated use led not only to social harm, but to severe medical complications. The most dramatic chronic medical issue to gain recognition in the early 21st century was ketamine-induced cystitis. Around the mid-2000s, urologists in Hong Kong, then Australia, and several European centers began seeing a new pattern in young, otherwise healthy people. Extreme urinary frequency, urgency, suprapubic pain, and blood in the urine, all in the context of heavy ketamine use. Further evaluation showed severely contracted, fibrotic bladders. Some patients needed reconstructive surgery. A few underwent complete bladder removal. Pathology reports described ulceration, hemorrhagic inflammation of the bladder lining, and progressive scarring. By 2007-2008, case series in major urology journals had put the global medical community on notice. Animal and tissue work suggested that ketamine and its metabolites in urine could directly injure the bladder lining in susceptible users. Stopping the drug early could lead to partial recovery. Prolonged exposure carved permanent damage. For a medication long considered a dependable asset in surgery and trauma care, the idea that it could shrivel a young adult's bladder into a painful remnant felt like a visceral reversal, a kind of organ-level backlash from a drug once praised for preserving life. Faced with both acute and chronic harms, medicine responded at multiple levels. Clinicians who were early adopters of ketamine in psychiatry leaned conservative. Initial trials at major centers in the US and Europe built rigid screening walls, excluding people with active substance use disorders, histories of psychosis, significant cardiovascular disease, or poorly controlled hypertension. Dosing was limited to sub-anesthetic infusions under strict supervision, and patients were observed afterwards for safety. Professional societies and hospital committees began sketching formal guidance. As off-label ketamine clinics sprang up across North America in the 2010s, differences in practice, varying doses, uneven screening for addiction, inconsistent monitoring drew concern. Regulators took notice. In the US, ketamine had long been a controlled substance. As its psychiatric use expanded, the Food and Drug Administration began to insist that new proprietary formulations carry explicit safety programs. When an intranasal S-enantiomer product, S-ketamine, developed by a major pharmaceutical company, gained approval in 2019, it did so under a risk evaluation and mitigation strategy, REMS. Patients could only receive the spray in certified clinics. They had to be monitored on-site for a set period after each dose. The label warned clearly about sedation, dissociation, and abuse potential. In effect, regulators paired recognition of clinical promise with institutional safeguards against misuse. If one chapter of ketamine's story is caution and harm, the next is a small, carefully documented miracle written in footnotes, case reports, and early-phase trials. The account of ketamine's antidepressant action is, in many ways, a story of chance observation elevated into formal science. In anesthetic suites and pain clinics in the 1990s and early 2000s, doctors occasionally noticed that patients who received low-dose ketamine infusions for pain or anesthesia reported feeling better emotionally for days afterwards. These early hints were swapped quietly in hallways or published as single-case reports, not yet robust enough for funding panels, but intriguing enough to stir methodical minds. In 2000, a small but rigorous study appeared in Biological Psychiatry, led by Robert M. Berman and including researchers such as Dennis Charney and John H. Crystal. It documented rapid antidepressant effects after a single subanesthetic IV infusion of ketamine in a small group of patients with depression. The shifts weren't subtle. Mood improvements could be seen within hours. The authors were appropriately modest and cautious, but the pattern they reported was compelling. What made it especially striking was the timing gap between ketamine's few hours of administration and the weeks typically needed for standard antidepressants to show benefit. In a field where wait 6 to 8 weeks had long been the reality, the idea that you could see meaningful relief from suicidal ideation and severe depression within a day felt like a new physical law. A more definitive milestone came in 2006 at the National Institute of Mental Health. Carlos A. Zarate Jr. and colleagues published a randomized, placebo-controlled crossover trial that quickly became a landmark. They enrolled patients with treatment-resistant major depression people who had already failed multiple conventional therapies and gave each person, on different days, both ketamine and placebo infusions in random order, using that by then standard 0.5 mg/kg dose over 40 minutes. The results were attention-grabbing. A large proportion of patients showed significant symptom reduction within 24 hours, with some retaining improvement for days to a couple of weeks. The sample was small compared to big registration trials used for drug approval, but the design was solid and the effect sizes large. That sparked a wave of replication attempts. Over the next decade, multiple small randomized trials and meta-analyses converged on the same finding. IV ketamine, at sub-anesthetic doses, produced rapid, clinically meaningful antidepressant responses in a substantial subset of people with treatment-resistant depression. The response rates were high in the first 24-48 hours, though the duration varied. Some patients stayed improved for weeks. Most relapsed sooner, leading clinicians to test maintenance strategies. Repeated infusions over days or weeks, then boosters timed to symptom return. Parallel studies explored ketamine's impact on suicidal thinking. Several small trials suggested that a single low dose could rapidly cut the intensity of suicidal ideation. Emergency departments, inpatient psychiatric units, and even hospice programs took notice. The possibility that an intervention could shift suicidal risk within hours reshaped expectations in a field accustomed to slow-onset treatments. This clinical surprise forced changes in practice, policy, and basic science. Academic centers Yale, Mount Sinai, the NIMH, and others began running structured ketamine programs with well-defined protocols and exclusion criteria. At the same time, the practical and emotional urgency experienced by patients and families and the relative simplicity of administering IV ketamine in an outpatient setting led to a proliferation of off-label infusion clinics outside academia. By the early 2010s, commercial ketamine clinics were opening across the US, Canada, and parts of Europe and Australia. They offered hope, but also uneven adherence to best practices. Professional organizations and regulators responded, slowly and sometimes clumsily, with calls for standardized screening, clearer consent processes that explicitly outlined unknowns like long-term safety and risks of bladder or cognitive harm, and robust monitoring. Clinically, the antidepressant effect of ketamine raised a central mechanistic question. How exactly does this happen so fast, and why does the effect sometimes outlast plasma levels of the drug by days or more? The classical answer that ketamine is an NMDA receptor antagonist is correct, but incomplete. Ketamine's antagonism of NMDA receptors clearly sits at the beginning of the chain, but does not by itself explain the full antidepressant story. The paradox became obvious when other NMDA antagonists failed to reproduce ketamine's clinical profile. Memantine, a low-affinity NMDA blocker used in Alzheimer's disease, did not show consistent antidepressant benefits in trials. Other NMDA antagonists generated psychotomimetic effects without the robust and sustained antidepressant response associated with ketamine. This pushed researchers toward a more nuanced model. The disinhibition hypothesis gained momentum in the late 2000s and early 2010s. The idea was that ketamine disproportionately targets NMDA receptors on fast-spiking, parvalbumin-positive GABAergic interneurons in the cortex. These interneurons normally act as brakes on excitatory pyramidal cells. When ketamine partially silences those brakes, pyramidal neurons become disinhibited, releasing a surge of glutamate. That glutamate, in turn, hits AMPA receptors on postsynaptic cells. AMPA receptor throughput becomes the critical next step. In rodent models, blocking AMPA receptors erases ketamine's antidepressant-like behavioral effects, strongly suggesting that AMPA-mediated signaling is essential. The now famous 2010 science paper by Lee and colleagues tied this neurocircuit story to structural plasticity. In rodents, they showed that ketamine increased synapse number in the prefrontal cortex, and that blocking mTOR, the mammalian target of rapamycin, a key regulator of protein synthesis, blocked both synaptogenesis and the behavioral antidepressant effect. The suggested sequence went like this: brief NMDA receptor blockade, disinhibition of pyramidal cells, glutamate surge, AMPA receptor activation, BDNF release, mTOR pathway activation, and rapid synthesis of synaptic proteins, collectively rebuilding atrophied synapses. BDNF became a central actor in this model. Animal experiments indicated that ketamine's effects were reduced or absent in animals with impaired BDNF signaling, such as those carrying the human BDNF Val-Syn66 MET polymorphism. Another molecular player, EEF2 kinase, regulates translation. By inhibiting EEF2 kinase, ketamine removes a brake on BDNF translation and allows a burst of protein synthesis. This mechanistic framework, glutamate surge, AMPA engagement, BDNF, mTOR, synapse repair, offered an elegant explanation for how a short-lived pharmacological event could trigger longer-lasting network changes and symptom improvement. But the story did not end there. In 2016, a group led by Vasiliki Zanos published a paper in Nature that shifted attention to a ketamine metabolite, 2R6R hydroxynorketamine, 2R6R-HNK. In mice, 2R6R-HNK produced rapid antidepressant-like effects without significant NMDA receptor blockade and without typical ketamine-like dissociation. The suggestion was provocative. Maybe ketamine's antidepressant power didn't depend entirely on NMDA receptor antagonism, but on a downstream metabolite with different receptor targets and fewer side effects. For a time, 2R6R-HNK became a hot topic in both academic and startup circles. If you could isolate or synthesize a metabolite that maintained the rapid antidepressant effect while eliminating dissociation and abuse potential, you might have the ideal next-generation drug. Multiple labs attempted to replicate the findings in various animal models and dosing paradigms. Results were mixed. Some studies supported HNK's efficacy, others did not. Questions about dose, species differences, and off-target effects lingered. The metabolite hypothesis opened promising doors, but did not close the debate on mechanism. Another twist came when a clinical study found that pre-treatment with naltrexone, an opioid receptor antagonist, appeared to blunt ketamine's antidepressant effect in humans. This hinted that opioid system signaling might play a modulatory role, even if NMDA receptor and glutamate mechanisms remained central. The idea that ketamine's mood effects could be partially dependent on mu-opioid receptors sparked concern, particularly in an era already scarred by the opioid epidemic. Subsequent studies have produced conflicting results, and the extent of opioid involvement remains unsettled. What emerges from all this is not a single neat mechanism, but a network of overlapping pathways. NMDA receptor antagonism is a proximal trigger. Disinhibition and glutamate surges follow. AMPA receptors and downstream cascades, BDNF, mTOR, local protein synthesis, translate short-term changes into structural remodeling of synapses. Active metabolites may contribute. Opioid systems might modulate subjective and therapeutic effects. Inflammatory signaling and monoaminergic changes may play background roles. Almost every component enjoys both supporting evidence and credible challenges. Layered on top of that uncertainty is the translation problem. Depression-like behavior in rodents is not depression in a human being. Learned helplessness, forced swim tests, and chronic stress models are useful, but they capture only small facets of human mood disorders. The gulf between animal and human minds complicates the leap from mechanism to marketed drug. Drug developers responded with multiple strategies. Some staked their efforts on esketamine, the S enantiomer, arguing that its higher potency at the NMDA receptor and slightly different pharmacology might offer clinical advantages. Janssen's intranasal esketamine program eventually succeeded in obtaining FDA approval in 2019, under tight safety controls. Other groups chased the HNK story or pursued entirely different targets downstream of glutamate AMPA potentiators, mTOR modulators, agents acting at the glycine site of the NMDA receptor such as rapastenel, GALEX13, and subunit-specific NMDA antagonists. Many of those candidates met with disappointing results in later-stage trials and were abandoned or deprioritized. The result is a field in productive tension. Clinicians and patients now possess a powerful, fast-acting antidepressant tool whose exact mechanisms are incompletely mapped, and whose risk profile dissociation, cardiovascular changes, potential for misuse, possible cognitive impacts with heavy chronic use, and bladder toxicity in some recreational users demands respect. At the same time, research infrastructure continues to expand. From Boston and New Haven to Beijing and Berlin, labs are running animal studies, neuroimaging projects, EEG analyses, and long-term follow-ups. Academic medical centers across North America, Europe, and beyond continue to refine protocols, track outcomes, and develop best practices. The mechanistic controversies not only keep conferences lively, they sustain funding and intellectual energy in a branch of psychiatric neuroscience that had for years been criticized as slow and unimaginative. If there is a single human thread at the junction of all these chapters, it is this. Science moved forward because clinicians listened to patients, recorded what they saw, and tested their observations. Regulatory frameworks tightened because the harms, no matter how rare in clinical settings, were real in broader populations. Ketamine has taught psychiatry that mood can be shifted much faster than previously assumed, that synaptic plasticity is a viable therapeutic target, and that altering consciousness pharmacologically comes with ethical and physical costs that require serious stewardship. The questions that remain about mechanisms, long-term safety, optimal dosing, integration with psychotherapy, and equitable access are not minor technicalities. They are the work of years. They keep researchers up late parsing data. They occupy institutional review boards, and they complicate the quiet conversations clinicians have with patients on the edge of despair. The story, in other words, is still very much in progress. Measured now in multi-center trials, real-world registries, safety warnings, and the guarded hope of people for whom conventional treatments were never enough. By the time serious multi-center randomized trials were being planned in the 2010s, those early, electrifying single-infusion studies run late at night in quiet hospital rooms had already taken on a life of their own. In 2000, that first small controlled study had whispered to psychiatry that an anesthetic might lift depression in hours. In 2006, Carlos Zarate and his team at NIMH amplified that whisper into a clear signal, showing rapid antidepressant effects in treatment-resistant patients. Replication attempts at Yale, Mount Sinai, and other major centers gave the finding enough weight that industry and regulators could no longer ignore it. The initial wave of research was mostly academic small samples, crossover designs where each patient served as their own control, and short observation windows. These early trials defined what clinicians came to recognize as ketamine's antidepressant signature. Onset within hours, peak benefits in the first day or two for many, and then a gradual fading over days to a couple of weeks unless treatment was repeated. These sessions were intimate, heavily monitored affairs, 4 pumps humming, ECG tracings glowing on monitors, research nurses carefully charting blood pressure, dissociation scores, and mood ratings. But they were also vulnerable to obvious critiques. Sample sizes were small. Most used just a single infusion. Follow-up times were limited. And there was a major methodological problem. Ketamine's dissociative and physiologic effects make it very hard to maintain blinding. If a patient suddenly feels space bending and hears music differently, and if a clinician sees pupils dilate and blood pressure jump, everyone in the room knows it isn't saline. Critics weren't splitting hairs, they were pointing at a core challenge in evaluating any psychoactive drug. When a treatment has powerful subjective effects, expectation becomes an active variable, not just background noise. As ketamine's reputation grew, pharmaceutical companies and regulatory agencies shifted from curiosity to calculation. Janssen, the drug development arm of Johnson & Johnson, decided to pursue a refined form of the molecule, the S-enantiomer esketamine, delivered intranasally. That was as much a business decision as a scientific one. A single enantiomer in a proprietary delivery system could be tightly patented and branded. Racemic ketamine, generic and inexpensive, would remain in a gray zone used off-label, but unlikely to be commercialized in a way that fit the tidy economics of modern pharma and insurance systems. Janssen's program set the stage for a new chapter, a suite of large multinational randomized trials with defined endpoints and an explicit goal of regulatory approval. These pivotal programs had to address earlier study limitations while satisfying regulators' concerns. To tackle the blinding problem, some trials used active comparators like midazolam, which causes sedation but not the same type of dissociation, to better mask which patients were receiving the active study drug. Other trials used parallel group designs rather than crossovers to mimic real-world practice more closely. Across multiple transform, short-term efficacy, and sustain, maintenance relapse prevention studies, Janssen gathered data on intranasal esketamine plus an oral antidepressant versus oral antidepressant plus placebo spray. Some trials showed statistically significant reductions in depression scores, particularly in treatment-resistant populations. Others were more equivocal. Relapse prevention designs, where only responders were randomized to continue esketamine or switch to placebo, suggested that ongoing treatment delayed relapse. But these studies raised their own questions. Was relapse in the discontinuation arm due purely to loss of pharmacological action, or did withdrawal or expectancy effects play a role? Meta-analyses aggregating both IV racemic ketamine and intranasal esketamine studies in the mid-2010s painted a consistent but complex picture. Ketamine-based treatments produced large, rapid improvements in depressive symptoms, but the average duration of benefit after a single dose was relatively short. Repeated dosing strategies could extend benefit, but the long-term risk-benefit balance remained uncertain. Heterogeneity in study designs, dosing, route of administration, whether patients continued other antidepressants, and use of active placebos, meant pooled effect estimates had to be interpreted cautiously. Safety remained a constant through line. Short-term, the main issues in controlled settings were transient spikes in blood pressure and heart rate, acute dissociation, nausea, and occasional anxiety or agitation. Clinical teams mitigated these with monitoring, pre-infusion counseling, and low-dose anxiolytics when needed. But above this narrow window of controlled medical use loomed the larger, rougher data from recreational communities, chronic heavy users with bladder injury, cognitive impairment, and dependence-like behaviors. Animal studies still raised concerns about potential neurotoxicity with repeated or high-dose exposure, particularly in development. Regulators had to weigh this patchwork of evidence against a stark backdrop. Treatment-resistant depression carries a high risk of suicide, hospitalization, and long-term disability. No existing drug class had clearly solved that problem. In early 2019, the US Food and Drug Administration made its call. After reviewing Janssen's data package, multiple Phase 3 trials, analyses of onset, magnitude and duration of effect, and safety reports, the FDA approved intranasal esketamine, Spravato, for adults with treatment-resistant depression. A later indication was added for depressive symptoms in adults with major depressive disorder accompanied by acute suicidal ideation or behavior. This approval didn't come as a blank check. It came with visible guardrails. The FDA required a REMS program, risk evaluation and mitigation strategy. Under REMS, esketamine had to be administered only in certified healthcare settings by trained staff. Patients had to be observed on-site for at least 2 hours after dosing, and they could not take the spray home. The label carried prominent warnings about sedation, dissociation, abuse potential, and suicidal risk. The agency mandated post-marketing studies to assess long-term cognitive effects, abuse liability, and sustained efficacy over time. In essence, regulators carved out a controlled corridor for access. They acknowledged the urgent need for new options while building in mechanisms to reassess safety and effectiveness as real-world use expanded. But regulation of Spravato didn't cover the broader universe of IV ketamine treatments, which were already being offered off-label in private clinics. Those clinics, some founded by psychiatrists, others by anesthesiologists, nurse practitioners, or multi-specialty groups, had begun to appear even before esketamine's approval. They multiplied quickly in the 2010s, especially in urban centers in the US, Canada, and Australia. Their websites advertised rapid relief for treatment-resistant depression, anxiety, PTSD, and sometimes chronic pain. Many offered package plans, an induction course of 6 infusions over 2 or 3 weeks, followed by maintenance infusions at individually determined intervals, sometimes on a subscription basis. Most of these clinics used generic racemic ketamine given intravenously, off-label. Legally, in many jurisdictions, this fell within standard medical practice. Physicians may prescribe drugs off-label when supported by reasonable evidence and with informed consent. But the scale and pace of ketamine's off-label psychiatric use were unprecedented. Treatment protocols varied widely: 0.5 mg over 40 minutes, 0.7 mg rapid IV pushes instead of slow drips, occasional intramuscular or intranasal routes with compounded formulations. Monitoring standards also diverged. Some centers were equipped like mini hospitals, with full resuscitation gear and anesthesiologists on site. Others resembled upscale wellness spas, with comfortable recliners, eye masks, playlists, and relatively minimal medical presence. Screening for cardiovascular disease, substance use, and psychiatric risks was robust in some practices, cursory in others. Informed consent ranged from thorough, multi-session conversations to a single page signed minutes before the first infusion. Clinician qualifications spanned a wide spectrum, from board-certified psychiatrists and anesthesiologists collaborating in multidisciplinary teams to solo practices led by mid-level providers with variable psychiatric training. Professional societies scrambled to keep pace, releasing position statements and guidelines that recommended careful screening, standardized dosing, close monitoring, and follow-up. But the marketplace moved faster than consensus documents. The economics were blunt. Many clinics charged hundreds to more than $1,000 per infusion, as insurers often refused to cover off-label ketamine for psychiatric indications. Out-of-pocket costs quickly became a barrier. Some clinics sought contracts with employers or insurers. Others remained entirely cash-based. Meanwhile, esketamine, though expensive, had the advantage of an official indication and occasionally received coverage for eligible patients. But access was constrained by REMS-certified site availability and prior authorization hurdles. This dual-track system created a paradox. Racemic ketamine, the older, cheaper drug, was available in more settings, but under a patchwork of standards. Esketamine, the newer, branded, and pricier enantiomer, was more tightly controlled and more consistently monitored, but financially out of reach or logistically inaccessible for many. A drug that had begun life as a cost-effective anesthetic solution in countries with limited resources was now, in high-income nations, a relatively costly psychiatric intervention. often available primarily to those able to pay or navigate complex insurance systems. This commercialization wave raised ethical questions. Was the rapid growth of ketamine clinics driven more by strong evidence or by market demand and patient desperation? Were some patients being overtreated or kept on indefinite maintenance schedules without clear endpoints or long-term safety data? How should clinicians communicate the knowns and unknowns while patients were in crisis? The dissociative effects of ketamine added another layer of complexity to consent and ethics. The very experience that could help break rigid patterns of thought might also, at least temporarily, impair judgment or amplify suggestibility. Most responsible programs approach this by securing consent during clear-headed periods, revisiting discussions over time, and involving family members when appropriate. But anecdotal reports circulated of rushed consents in boutique settings or patients encouraged into long, costly treatment plans without robust evidence. Diversion risk, while not as dramatic as with opioids, remained real. Increased medical handling of ketamine meant more opportunities for theft, miscounted vials, and informal sharing. Clinics tightened inventory procedures, adopted secure storage, and sometimes had to confront law enforcement reporting requirements if stock went missing. On the international stage, debates over global scheduling intensified. Some countries, particularly in Asia, pushed for stricter international controls in response to widespread recreational use and associated harms. But public health experts and global surgery advocates warned that aggressive scheduling could choke off ketamine supply to low-resource operating rooms and obstetric wards, where it might be the only viable anesthetic option. WHO expert committees repeatedly concluded that the dangers of restricting medical access, especially in poorer countries, outweighed the benefits of using international scheduling as a blunt anti-recreational tool. In the US, ketamine had long held a controlled status, reflecting its legitimate medical use alongside its abuse potential. Esketamine entered that same controlled framework, but with the added layer of REMS oversight. The resulting regulatory architecture was patchworked and pragmatic rather than pristine. It tried to balance access for high-need psychiatric patients, safety for the public, and preservation of ketamine's role in anesthesia worldwide. Beyond law and regulation, ketamine's repurposing triggered a political and economic discussion about how old molecules become new money. Critics pointed to the stark price difference between cheap generic IV ketamine and expensive brand-name esketamine, arguing that companies were remonetizing an old public domain compound through formulation and marketing. Supporters countered that turning a legacy drug into a standardized, FDA-approved and safety-embedded product required substantial investment and justified higher prices. For clinicians and patient advocates, the priority was often more basic, making sure people who could benefit from ketamine therapies had safe, affordable access while learning from real-world outcomes. Many academic psychiatrists who had been part of early research efforts pushed for national and international registries to track both benefits and harms in routine practice. Some called for comparative effectiveness studies directly pitting racemic IV ketamine against intranasal esketamine in similar populations. Others urged insurers and health systems to prioritize coverage of approaches with the best balance of evidence and cost-effectiveness. Patient organizations, especially those focused on treatment-resistant depression and suicide prevention, pressed for broader access with appropriate safeguards. They highlighted stories of lives dramatically changed, sometimes saved, after a handful of ketamine sessions. At the same time, they acknowledged the unevenness of access and the financial burden on many families. Public health and ethics scholars pointed to issues of justice. Should finite mental health resources be directed toward an expensive, partially understood intervention, while more scalable, lower-cost treatments remain underfunded? How should health systems prioritize among patients, especially where ketamine clinic capacity is limited? What obligations do commercial clinics have to serve lower-income populations or to contribute data to registries? The answers, in practice, have been piecemeal. Some academic centers and nonprofits have built sliding-scale programs or included ketamine treatments in broader integrated care pathways. Others have remained selective, citing constrained resources and lingering safety questions. The landscape that emerged is uneven. Some patients receive ketamine in the context of robust research protocols and integrated psychotherapy. Others encounter it as a standalone commodity in a marketplace. Legally, ketamine's psychiatric use sits at the intersection of off-label medical practice, evolving evidence, and active oversight. State medical boards in the US and national regulators elsewhere began issuing advisory guidelines on ketamine use for mood disorders, covering clinician qualifications, necessary monitoring, and screening requirements. These documents don't have the force of criminal law, but they frame professional standards and can shape malpractice risk, insurance coverage, and institutional policies. At the same time, the politics of repurposing ketamine for depression and suicidality spilled into broader drug policy debates. If an old anesthetic could be turned into a high-cost psychiatric product, what did that say about incentives in biomedicine? Were we rewarding genuine innovation or simply regulatory arbitrage? Advocates for drug repurposing argued that finding new life-changing uses for existing compounds is one of the most efficient ways to address urgent medical needs, especially in psychiatry. Critics worried that the benefits of publicly funded or long-standing research were being privatized without sufficient attention to equity. In practice, ketamine became a test case for a 21st century pattern, an off-patent molecule with emergent uses, a branded derivative with REMS protections, and a network of independent clinics operating at the edge of, but inside, professional norms. Evidence, market forces, and regulatory caution interacted in real time, often with patients caught in the middle. Yet underneath all the policy, money, and science, the lived reality remained starkly human. Clinicians who saw a patient's suicidal rumination quiet within hours of an infusion couldn't simply shrug and wait for decades-long outcome data. Regulators, confronted with meaningful effect sizes in treatment-resistant groups, had to make decisions before the perfect evidence existed. Patients, having cycled through multiple failed treatments, often viewed ketamine as a last necessary gamble. Looking back, the FDA's approval of intranasal esketamine in 2019 reads like a pivot point, a conditional yes, framed by strong guardrails and ongoing questions. It was a recognition that the old rulebook of slowly acting antidepressants no longer fully applied, and that new tools would require new oversight structures. What followed was not a final resolution, but a longer phase of careful watching, post-marketing surveillance for cognitive or urinary complications, growing registries of real-world IV ketamine outcomes, and head-to-head studies comparing different delivery methods and integration models with psychotherapy. Insurance coverage evolved slowly. Some payers began covering esketamine under narrow criteria. Others, more hesitantly, reimbursed off-label IV ketamine when well-documented and supervised. Many patients still paid cash. The narrative of ketamine in psychiatry thus became not a story of simple triumph, but one of ongoing negotiation between speed and safety, access and oversight, public health caution, and individual desperation. As new trials evaluated maintenance regimens, tapering schedules, and combinations with talk therapy, it became clearer that ketamine is neither a one-off miracle nor a trivial tool. For some patients, a handful of infusions provided months of relief and a new foothold in life. For others, benefits were brief or absent. For a minority, side effects were intolerable or frightening. For a smaller group still, the drug risked fostering psychological or behavioral dependence. The reality, as usual, refused to obey simple slogans. Ketamine was a breakthrough, but a complicated conditional one. It opened the door to a new class of fast-acting glutamatergic treatments, forced psychiatry to reckon with brain plasticity in real time, and exposed weaknesses in how our systems handle repurposed molecules, commercial incentives, and equitable access. Through it all, the most important questions remain disarmingly straightforward. How do we help people whose nights are swallowing them without causing new forms of harm? How do we harness a drug that can rearrange the experience of being alive for a short time and translate that into durable healing rather than fleeting escape? How do we ensure that the possibility of quick relief doesn't become the basis for unchecked commercialization or hidden long-term costs, financial or biological? Those questions have no final, simple answers. They are being worked out day by day in quiet clinics, crowded ERs, advisory committees, insurance offices, and research labs, one infusion, one trial, one policy decision at a time. Ketamine's entry into psychiatry didn't erase its anesthetic history, it seeded new projects all around it. The compound left a kind of spore in the minds of pharmacologists and investors alike. A sense that if one old anesthetic could open a rapid plasticity window, then perhaps a better, cleaner version was waiting to be found. The very qualities that made ketamine so powerful in the clinic, its swift impact on synapses, its ability to reshape mood in hours, were also the traits that made it difficult to patent in its generic form and awkward to manage in a culture hypersensitive to drug misuse. Pharmaceutical strategy unfolded in a pattern the industry knows well. Take what works and try to refine it. One obvious move was to focus on mirror image forms, enantiomers. Racemic ketamine is an equal blend of S and R enantiomers. Janssen bet heavily on the S enantiomer, esketamine, reasoning that its greater potency at NMDA receptors might allow lower doses, faster onset, and perhaps a distinct safety profile. That bet led to Spravato, with its tightly regulated intranasal delivery and REMS program. On the other side of the mirror, R-ketamine began to attract interest in academic circles, particularly in Japan. Preclinical studies by Kenji Hashimoto and colleagues suggested that R-ketamine produced robust, long-lasting antidepressant-like effects in rodents, with fewer locomotor disturbances and possibly fewer psychotomimetic signatures than the S form. In some models, R-ketamine's effects outlasted those of the racemate. Japan's regulatory and research environment, often attentive to neuropsychiatric innovation, took notice. Small biotech collaborations explored whether R-ketamine could become a next-generation antidepressant with less baggageless dissociation, less abuse potential, but still rapid acting. Parallel to enantiomer exploration, the metabolite hypothesis continued to simmer. The idea that specific ketamine metabolites, especially 2R6R, hydroxine or ketamine, might mediate antidepressant effects without NMDA blockade or dissociation was alluring. If this were borne out, medicinal chemists could aim for drugs that skip the parent compound altogether, delivering HNK-like activity directly. A flurry of animal studies, molecular assays, and exploratory development programs followed. Some results were promising, others didn't replicate. The dataset is still unresolved enough that no HNK-based antidepressant has yet emerged as the definitive successor to ketamine itself. Attempts to refine NMDA modulation beyond global blockade followed multiple routes. One strategy was to target specific receptor subunits, such as NR2B selective antagonists like Traxoprodil and MK0657, in hopes of preserving antidepressant efficacy while sidestepping dissociative side effects. Early-phase human trials yielded mixed or modest results. Another approach was to act not as a blocker, but as a clever modulator at the NMDA co-agonist glycine site, tuning the receptor's activity rather than shutting it down. This was the logic behind Rapastinel, GLIX13, initially heralded as a ketamine-like antidepressant without the trip. Rapastinel's early small trials were tantalizing. The drug appeared to reduce depressive symptoms without triggering overt dissociation or psychotic-like experiences. Media narratives quickly adopted it as a proof of concept that one could have ketamine's benefits without ketamine's risks. But larger Phase 3 trials failed to meet primary endpoints, and development was halted. The molecule's story became an object lesson in the difference between early-phase significance and large-scale clinical robustness. Other efforts looked downstream, beyond NMDA itself. If ketamine's true power lay in enhancing AMPA receptor throughput and synaptic protein synthesis, perhaps direct AMPA potentiators, AMPA kinase, or mTOR targeting agents could deliver similar effects more safely. Several early candidates moved through preclinical pipelines, but translating these mechanistic hopes into human antidepressants proved difficult. Off-target effects, tolerability issues, and insufficient efficacy all thinned the field. Then came a more pragmatic strategy: combine modest NMDA antagonist activity with other known psychopharmacologic actions. Dextromethorphan, a cough suppressant with NMDA antagonism and sigma-1 activity, had long been available. Bupropion, a norepinephrine dopamine reuptake inhibitor, also inhibits CYP2D6, slowing dextromethorphan metabolism. Axsome Therapeutics combined the two into a single oral product, dextromethorphan bupropion, branded AXS-5, Orvility. In clinical trials, that combination showed antidepressant effects and eventually received FDA approval in 2022 for major depressive disorder. XS-05 isn't ketamine, but it is part of the same conceptual family. It represents a shift from a purely ketamine-centric vision to a broader glutamatergic toolkit. Old molecules repaired and repurposed to modulate NMDA and allied pathways in new ways. Alongside lithium, SSRIs, SNRIs, atypical antipsychotics, and psychotherapy, these drugs hint at a next wave of treatments that target synaptic plasticity more directly. All these pharmacologic maneuvers implied very different clinical futures. A non-dissociative metabolite or downstream modulator that worked might be prescribed by primary care physicians, taken at home, and monitored via telehealth, transforming rapid-acting antidepressants into everyday tools. Oral combinations like AXS-05 could be dispensed in pharmacies like any other medication, without the infrastructure needed for infusion monitoring. By contrast, drugs like esketamine, bound to REMS programs and in-clinic administration, keep treatment anchored to specialized settings. They demand physical clinic space, staffing, scheduling infrastructure, and reimbursement models for observed dosing. Each design decision, a nasal spray versus an infusion, an oral pill versus an injection, carries logistical and ethical consequences. Who can realistically access the treatment? Who pays? Who supervises? Who profits? As ketamine, esketamine, and related agents spread into practice, the question of integration with psychotherapy moved from theory to reality. The purely pharmacological model treats ketamine as a fast-acting antidepressant in the same conceptual bucket as SSRIs, something given episodically or on a schedule, with symptom monitoring and standard medication management. But a different model, emerging at the intersection of psychedelic research and experiential therapies, framed ketamine as a catalyst for psychotherapeutic work. This integrated approach, often called ketamine-assisted psychotherapy, KAP, takes cues from psychedelic-assisted therapy protocols using substances like psilocybin and MDMA. In KAP, medication sessions are bookended by structured talk therapy, preparation sessions to build rapport, clarify goals, and manage anxiety. Dosing sessions in which a therapist is present, often with carefully chosen music and a controlled environment. And integration sessions to process experiences and anchor insights into lasting behavioral change. The logic is straightforward. Ketamine can disrupt entrenched patterns of thought, soften rigid defenses, and temporarily alter self-perception. Guided appropriately, that window might enable patients to revisit trauma, explore alternative narratives, or access emotions that felt locked away. Without support, the experience might remain a disjointed trip, memorable, but not transformative. Data comparing KAP to medication-alone models are still emerging. Some small studies and observational reports suggest that coupling ketamine with targeted psychotherapy may extend duration of benefit or improve functional outcomes. But the evidence remains early and heterogeneous. Trials differ in dosing strategies, psychotherapeutic frameworks, and patient populations, making direct comparisons difficult. Still, the momentum in certain clinical communities, especially those already interested in psychedelic-assisted therapies, is clearly toward integration rather than pharmacology alone. That move raises its own structural questions. KAP requires therapists comfortable working alongside altered states and trained in integration methodologies that are still considered fringe in many conventional programs. It demands more time per patient session and, therefore, different reimbursement models than brief medication management visits. For larger systems, that means revisiting staffing, billing, and training from the ground up. Training became a pinch point. How do you prepare clinicians for a treatment that straddles anesthesia, psychiatry, and experiential therapy? In the late 2010s and early 2020s, a cottage industry arose around ketamine training. Continuing medical education courses, weekend seminars, certificate programs blending didactics with supervised practice. Some focused on safe infusion protocols for psychiatrists and anesthesiologists. Others emphasized psychotherapeutic frameworks, teaching clinician therapist teams how to navigate dissociation, transference, and integration. Professional societies tried to impose order on this ferment. Position papers and guidelines recommended minimum standards: comprehensive psychiatric assessment, medical screening, cardiac history, substance use, pregnancy, neurologic conditions, informed consent that acknowledges uncertain long-term risks, monitoring of vitals during sessions, post-dose observation, and systems for tracking symptoms, functioning, and adverse events. Suggestions for registries, national or international databases to collect outcome and safety information grew louder. Maintenance strategies, how to support patients after an initial response, became another focus of debate and experimentation. Should patients receive a fixed induction course of 6 to 8 sessions and then be followed with as-needed boosters? Should some transition to oral antidepressants, therapy, or other interventions in the window of improved functioning? Should ongoing ketamine use be limited by time, number of sessions, or clear clinical benchmarks? Different clinics adopted different rules, often guided as much by experience and capacity as by data. Safety monitoring also evolved. Short-term, most clinics tracked blood pressure, heart rate, and oxygen saturation before, during, and after sessions, requiring patients not to drive or operate machinery the rest of the day. Longer-term, vigilance centered on urinary and cognitive health, especially for patients receiving frequent or prolonged treatments. Questions of tolerance and dependence were never far from view. Could some patients gradually become reliant on ketamine, not just physically, but psychologically or financially? How would clinicians recognize that turning point and respond? The ideal workforce for these therapies looked multidisciplinary: psychiatrists for diagnosis and medical oversight, anesthesiologists or experienced medical staff for infusion management, nurses for monitoring, therapists for preparation and integration, addiction specialists for evaluating risk and managing problematic use. But in practice, many clinics operated with leaner teams, shaped by local regulations, resources, and economics. Beyond day-to-day practice, ketamine's repurposing reshaped psychiatry's sense of what is possible. For decades, the dominant narrative had been slow change. Antidepressants that take weeks to work, psychotherapy that unfolds over months or years, electroconvulsive therapy as a physically dramatic but logistically complex option. Ketamine shattered that timeline. It made clear that some patients can experience major symptomatic relief in a matter of hours. That realization raised expectations among patients, families, and clinicians. It also redirected scientific attention toward synaptic plasticity, circuit-level dynamics, and the interface between acute changes in consciousness and longer-term shifts in mood. Funding agencies and young investigators began to prioritize projects on glutamate, BDNF, mTOR, and neural network connectivity. Functional MRI studies examined how ketamine reshapes connectivity between the prefrontal cortex, limbic structures, and default mode networks. EEG studies sought signatures correlated with treatment response. Blood and CSF assays hunted for candidate biomarkers. BDNF levels, inflammatory markers, genetic variations that might predict who would respond best or be at higher risk for side effects. Those efforts promised something psychiatry has long lacked: precision. Rather than trial and error across months, clinicians might one day use baseline neuroimaging, electrophysiology, or lab markers to predict response to ketamine or ketamine-like drugs and tailor treatment accordingly. That potential is still emerging, but the direction of travel is clear. At the same time, ketamine forced a deeper ethical reflection on the medical use of altered states. The dissociation that accompanies ketamine treatment is not a trivial side effect. For many patients, it's a profound existential event. Some describe feelings of ego dissolution, encounters with symbolic or spiritual content, or an eerie sense of detachment from their life story. How much of ketamine's therapeutic benefit flows through these subjective experiences? Are they incidental or integral? Does minimizing dissociation in pursuit of a cleaner drug risk stripping away something crucial? These questions blur the line between neuroscience and philosophy. They also have practical implications. If the subjective experience matters, then setting, therapeutic framing, and integration become more than just add-ons. They become central to ethical and effective practice. If, on the other hand, the experience is largely epiphenomenal, then the drug development goal of finding non-dissociative rapid antidepressants becomes more straightforward. The future of glutamatergic therapies will turn on how these questions are answered, both empirically and culturally. Several likely trends are already visible on the horizon. More refined molecules. Medicinal chemistry will continue to chase compounds that preserve ketamine's rapid synaptogenic and antidepressant properties while minimizing dissociation, abuse potential, and end-organ toxicity. Enantiomer-specific drugs, metabolite analogues, and receptor modulators will keep moving from bench to early-phase trials. Broader routes of delivery, oral agents like dextromethorphan bupropion, Orvility, signal an expansion beyond clinic-based infusions and sprays. As safety and efficacy profiles clarify, we may see more at-home treatments scattered along the glutamate axis. Deeper integration with psychotherapy. As psychedelic-assisted therapies move toward mainstream medicine, ketamine's hybrid role, drug and catalyst, will likely be codified more firmly. Training programs will formalize KAP methods. Clinical trials will test whether specific therapeutic frameworks, CBT, trauma-focused, psychodynamic, transpersonal models, enhance or extend ketamine's benefits. Stronger data infrastructure, real-world registries, and large pragmatic trials will be crucial to understand long-term outcomes, rare side effects, and comparative effectiveness among racemic ketamine, esketamine, and newer agents. These data will shape guidelines, reimbursement decisions, and standard of care definitions. Evolving regulation and reimbursement. Regulators will refine REMS and similar programs in response to mounting evidence, possibly relaxing or tightening requirements. Insurers and national health systems will continue to grapple with coverage, cost-effectiveness, and equity, deciding who gets these costly, labor-intensive treatments and under what conditions. Equity and access debates. The urban-rural divide, public-private split, and income-based disparities will remain central issues. Will ketamine and its successors become tools primarily for those with money and proximity, or will health systems find ways to integrate them into broader, more equitable care pathways? Ethics of commercialization. As more biotech and pharma companies develop glutamatergic drugs, the tension between innovation and profiteering will intensify. Policy discussions may push for more public-private partnerships, pricing transparency, or even new models for handling intellectual property on repurposed medications. Through all of this, ketamine's most enduring contribution may be conceptual. It demonstrated that depression is not necessarily a sluggish, immovable state, requiring only slow interventions. It showed that rapidly altering synaptic strength and network connectivity can change mood quickly, and that this can be done safely within limits if clinicians are careful. It reminded psychiatry that the brain is, at its core, a plastic organ even in conditions once considered stagnant or hopeless. There is a certain dark humor in the fact that a battlefield anesthetic, designed to tame PCP's excesses, ended up at the center of one of modern psychiatry's most active frontiers. But the irony carries a lesson. Tools built for one purpose can reveal capabilities far beyond their original design. Harnessing those capabilities without causing new kinds of harm requires humility, attention, and a willingness to adjust course. The future of glutamatergic antidepressants will not be written by molecules alone. It will be shaped by the clinics that administer them, the regulators who set boundaries, the insurers who decide what gets paid for, the therapists who frame and integrate the experiences, and most of all, by the patients who live through these treatments and report back what changed and what did not. In quiet infusion rooms with dimmed lights and soft music, in small offices where therapists and patients wrestle with new insights, in regulatory hearings where trial data and public testimony collide, ketamine's legacy is being updated almost daily. Some molecules will shine in early trials and then fade. Some clinics will uphold high standards, others will cut corners. Some policies will expand access responsibly, others will create new inequities. Through this churn, a simple but profound shift endures. Psychiatry now knows that depression and despair can, in some cases, be interrupted quickly via targeted neurobiological interventions. That knowledge cannot be unlearned. It raises expectations and responsibilities in equal measure. In the end, ketamine's story is not just about one chemical. It is about a field learning to move faster, to engage more deeply with brain circuits and consciousness, and to grapple more honestly with the ethics of induced altered states. It is about medicine negotiating with markets, regulators, culture, and human suffering over how a powerful tool should and should not be used. The molecule itself will sit in ampules and vials, indifferent to all this. It is we clinicians, scientists, policymakers, patients, who will decide which paths to build around it. Whether those paths become corridors of careful healing or chaotic detours will depend less on receptor diagrams and more on how deliberately we choose to act. For now, ketamine stands as both a bridge and a caution. A bridge from older, slower paradigms of treatment to a new era of rapid circuit-level interventions. A caution that speed without structure, power without stewardship, can repeat old mistakes in sharper forms. The work ahead is to carry forward the best of what ketamine has revealed about brains, about treatment, about urgency, while building systems capable of holding that knowledge safely. And somewhere, in a lab late at night, a researcher is pipetting a new compound into a well plate, watching cultured neurons under a microscope, asking whether this next molecule might offer ketamine's benefits with fewer shadows. Somewhere else, a nurse is adjusting a blanket for a patient as an infusion ends, asking softly, "How are you feeling now?" It is in these small, ordinary acts that the long, complex history of ketamine continues to unfold.